Good morning, Future Nurses America. Welcome to a new semester. I'm going to share my screen. So we're talking about intro to psychiatric mental health nursing, and I'm starting at slide 15. I hope you guys reviewed this PowerPoint before accessing this video. Now, I'm the type of professor that I'm not going to read off of each slide. As the semester moves forward, the expectation is that the slides I send out to you, you'll read your ATI, you'll research your textbook, and you'll be able to, we will be able to engage in a dialogue, okay? So review slides 1 through 14, 15, these are the stages of the therapeutic nurse-patient relationship. And this is basically what we will hope to accomplish as we're speaking to our patients. And as I have said before, you do have clinical expectations, but don't go into a psychiatric interview just hoping to get all your questions answered, okay? So during the orientation phase, you're building trust, okay? This is when you're sitting down with the patient, asking permission to speak with them. And remember, if you plan on taking notes, you have to ask their permission, because some patients are paranoid, and if you're writing things about them, they might get even more paranoid, okay? So again, first stage is the orientation phase, second is the working phase. This is when you're compiling your notes, you're doing some critical thinking, some teaching, you're teaching them some new skills, maybe medication management, and of course, they're teaching you new things as well. Okay, termination phase, this is when you summarize, this is when you're getting ready to speak with me, turning in your PUF worksheets. And during the termination phase, that's when you need to really think, what did I learn? What did I teach the patient, okay? And remember, it's very important when you leave for the day to make sure that you thank the patient for their time. The BAT technique, this is just a helpful communication tool to get information about your patient, but you can learn any technique or use any technique that you'd like, okay? So BATHE, background, you can talk to the patient. From your understanding, why did you come into the hospital? What were the circumstances that brought you in? Okay. Now that you're in the hospital, how are you feeling? Do you feel like you're improving, not improving? What have you learned? Okay. And now you're taken away from where you were at. What is troubling you right now? And what is your goal? What's the most important thing that you want to accomplish while you're here? And many of the patients will say that their goal is to get out of the hospital. And that's when you want to interject and say, so in order to get out of the hospital, what do you need to do? Okay. How are you handling this situation? This is a new environment. You're coming in contact with new people. How stressful is this to you? How do you handle your stress? And then that's when you can use some of your personal stress relievers, you know, positive coping mechanisms, okay? Talking to people, some exercise, and always proper diet, proper sleep, proper hydration. Those are important as well, okay? And be interested, show some empathy. Just don't sit there and as you're talking to the patient, writing all this stuff down. Make sure you make eye contact when appropriate, because that is very important. Time for some coffee with almond milk. Now, the Milrow is the environment. The Milrow, it's therapeutic. It's the environment where you're at. So whether you're at the urgent care or you're at the PUF unit, okay. And in the Milrow, okay, it's very important that it is not chaotic. Okay, it is not chaotic. For those of you that work, when you go into work, and I know I'm like this too, I can see who the charge nurse is, and I can almost bet what kind of day it is going to be, okay? And the middle room needs to be structured, needs to be a structured environment, because when it's structured, we're more able to learn. Imagine coming into my class where things were just really chaotic. Like I was talking to my phone, I wasn't paying attention to you, I wasn't teaching, I was reading the newspaper. All you guys were having your own conversations. We wouldn't be able to learn. Okay. And within the therapeutic community, the patient expected to do their part as well. They should behave right. They should be appropriate with their peers and with staff. And again, this is a psychiatric community, and sometimes patients will not act in a correct way. That's when we need to redirect them, de-escalate the situation, and show them the appropriate ways to act. Okay. So the basic meal rules assumptions, okay, are 1 through 7. Okay. And number 6 is very important. Well, they're all important, but I want to focus on 6, where it says inappropriate behavior is dealt with as it occurs. And I call this collecting stamps. What I mean by that, and I'm sure this has happened to every one of you, that maybe somebody hurts your feelings or does something that you don't approve of, but you don't address it. And it goes on and on and on and on. And the problem with you letting it go on and on and on and on is that whoever you're dealing with will think that it's appropriate behavior. Well, it's not. And then I've seen instances, and it's even happened within my life, where I haven't said anything. And then finally, the saying, the straw that broke the camel's back, is that you just laid on them. And normally when you laid on them all at once because you collected all these stamps, the interaction isn't good. So it's very important to address the inappropriate behavior so they learn. Okay. Does everybody understand? And at this time during the theory class, I'll be asking questions. Okay. So this is the team that we're dealing with: psychiatrists, clinical psychologists, and everybody else. One of the things that was left off the slide, does anybody know who else is part of the team? It would be the nursing student. Nursing students play a vital role in the team. And again, I've told you this, that I get more information from you guys than I do from a lot of my staff. Okay. So we talk about some modalities in treatment. There's different types of therapy, individual therapy, couples therapy, and you guys can read self-help groups, supportive and therapeutic groups. Okay. The supportive and therapeutic groups will be the groups that you're going to when you go to your meetings. Okay. And supportive groups are good because a lot of patients come into us thinking that they're the only people that are going through what they're going through, and that's not true. That's why NAMI is very important. That is why AA, NA, all these substance abuse groups are important. And I think what I'm going to do, and I'll mention this class, is you're going to be going to 4 substance abuse meetings and possibly 1 NAMI meeting as well. That little voice just told me, hey, tell them about the NAMI. So that's what I did. Okay. So interventions and groups. Okay. The group is defined as a collection of individuals. Okay. So we're a group, we're a collection of individuals, and we all have the common interest. My interest is that you guys can be the best that you can be. And with the knowledge that I'm providing for you, you can build on your foundation of nursing. Okay. And one thing to keep the group functional, we all need to respect each other, because if there's not respect within the group, then the group will slowly whittle away. Okay. Socialization is a big thing. And I talk to my patients about this all the time. We're not meant just to sit in a room and be by ourselves. So that's why it's important for you, the student, to get your patients out of bed and into groups, talking to them outside to exercise. And you'll see when patients are outside exercising, they are moving around, their whole mannerisms are totally different. Okay. So again, you want to respect their wishes, but you also want to make sure that they spend some time with you. And I tell patients this all the time. If you go home and you're sitting around all day and you think my life's bad, my life's bad, my life's bad, your life is going to be bad. Okay. So safety, that's the key role. That's the key role of the registered nurse. That's the key role of everybody on the unit. Okay. You want to know where your patient is at all times, just like I like to know where my students are at all times. Because what happens if you're missing a patient, that could be a bad thing. You're missing a student, that's a bad thing as well. Okay. So where it says assess psychodynamic issues, you really want to see who gets along with who. You want to monitor your patients. If they're escalating in their behavior going up, you want to de-escalate and bring their behavior down. Okay. And you want to evaluate the effectiveness of treatment, both your treatment you're giving to the patients and the medications they're taking. Okay. And one big thing that you'll learn when you're actually in a couple of weeks, art of delegation, you'll be giving assignments. And of course, when you're RNs, you'll be giving assignments as well. So you have to be able to trust the people that you're giving these assignments to. Okay. Process that information. Now we're going to be talking about medications. Medications are a big aspect of this course. Okay. So medication administration. We need to give it informed consent, and it's the law. And informed consent doesn't come from you, it comes from whoever is prescribing the medication, so myself or Dr. Blair. And it is your responsibility to make sure that there's a consent in the chart for each medication. Okay, and medications that require informed consent are your psychotropics, your antidepressants, anti-manic stimulants, and anxiolytics. Okay, those are the ones. So if you're a nurse working in any kind of setting, because psychiatric patients give birth, psychiatric patients are in the emergency room, they're in med surg, they're everywhere. If there's not a consent for one of those 5 classifications of medication, you do not give the medication. Do you understand that? Okay. What you would do is you contact whoever wrote that prescription, and it's their responsibility. It's their responsibility. So when we think about psychopharmacology, okay, you want to think, why am I giving this medication? What is this medication supposed to do? Okay. And you want to know what organs it affects, where it is metabolized through. So for example, 95% of all medications are metabolized through the liver. That's like our cleaning system. A small percentage are through the kidneys. And you want to know what effect of target symptoms. So I'm giving this Zyprexa. I'm giving this Abilify. I'm giving this Zoloft. These are all medications you'll learn today. What is this medication supposed to do? What is this medication supposed to do? And again, where it says lowest dose needed for maintenance, I tell my patients this all the time. My practice is the least amount of medication possible to help with the symptoms, okay? And because if 1 milligram will work, why give 5? Because normally the higher the amount of medication, the more side effects there are, okay? Where it says taper medications, we taper up and we taper down. Some classifications of medications, such as your benzos, your Ativan, your Xanax, your Librium, if you take those for a long period of time and you abruptly stop them, you run the risk of having seizures. And you always want to follow up with your primary provider. That's very, very important. And I know a lot of you have gone to your doctor, you've got antibiotics or whatever, and you take your antibiotics. Maybe you don't complete the course, but you don't go back. You always want to go back. Always want to go back. Take this slide, print it out, put it under your pillow because you will need it. Okay. So neurotransmitters are important for you, the student, to understand the concept, the pathology, and treatment. So there's 5 neurotransmitters there. And it's interesting when you read about medications associated with certain things. For example, where it says serotonin, excuse me, it treats mania and depression. Okay. So with serotonin, when you look up Zoloft, that's one medication. It's a selective serotonin reuptake inhibitor. So you should conceptualize in your mind. So if this is a selective serotonin reuptake inhibitor, this has something to do with mania and depression. Okay, just like norepinephrine, it helps with mania and depression as well. So if it you're reading on medications and it increases, decreases, stabilizes your norepi, hey, this has something to do with mania and depression as well. Same thing with GABA, dopamine, and acetylcholine. A lot of the antipsychotics that deal with assisting with schizophrenia, they act on dopamine regulation. So when you're looking these medications up and you see anything with dopamine, you know that it has something to do with schizophrenia or Parkinson's. Does everybody understand that? Does anybody have any questions? So since I see no hands raised, I feel that you guys know this. So remember, pharmacokinetics in the elderly, everything moves slower. That's why many times when we give medication to an elderly patient, it's at a smaller dose. In the PUF unit and in the urgent cares, if a patient, I believe, is over 55, we give them 1 milligram of Ativan, which is lorazepam, which is a benzo, instead of 2. Okay. So again, absorption, distribution, metabolism, excretion, it's all decreased. So remember that. Okay, very important in your practice. Okay. Per se, when we're testing for ATI and we're testing in my class, I'm not going to ask you like neuroleptics, tricyclic antidepressants, and benzos. Well, neuroleptics and tricyclic antidepressants, I'm not going to ask specific questions on those, but just remember things in the elderly, they can lower everything, lower BP, lower pulse. Benzos are very important because benzos can be addictive. And normally in my practice, I only prescribe benzos for 30 days. Nothing over that, because the longer you take, the more problems there can be. And the problem with giving benzos to an elderly patient is their half-life. And does anybody know what half-life is? It's the amount of time it stays in your system, okay? The half-life can be longer in the elderly, so they can be more sedate. So if they get up in the morning and they fall, they could break a hip and that could end their life, okay? So we normally do not give benzos for any lengthy time period in a elderly patient. So we're going to touch on 4 to 5 systems or diagnosis with schizophrenia, major depression, and bipolar. We're actually going to have full-length lectures on these, but I need to introduce the topic so we can go about medications, okay? So schizophrenia and psychotic disorders. And remember, if you ever have a patient that has an NOS diagnosis not otherwise specified, and it says psychotic disorder NOS, you're doing your systems template on schizophrenia. If you have a mood disorder NOS, you're doing your systems template either on bipolar disorder or major depression. Okay. Now with schizophrenia, I used to think this is a scary term. Okay, you'll deal a lot with a lot of patients on the unit have the disease of schizophrenia. Okay, it's a term used to describe a major psychotic disorder, and you'll have a disturbance in behavior, attention, motivations, feelings. A lot of patients with schizophrenia, they have positive and negative symptoms, and we'll talk about that in a second. Okay. One thing with the majority of patients with psychiatric illness, they are very intelligent. So let's learn some medications. So our first classification of medications are your typical antipsychotics. Your typical antipsychotics. Think of typical as older medications, okay? And typical antipsychotics, they treat positive symptoms of psychosis. So when we talk about positive symptoms, it's things that we don't have that are added to us. Like I can say with 99.9% certainty, everybody in this class does not have hallucinations, delusions, disorganized thinking and behavior, okay? So if these are things that are added, okay? For example, nobody in this class is have auditory hallucinations, visual hallucinations, so things that are added, okay? Your first medication that you need to know is Haldol, which is a typical antipsychotic. And in lecture, if I do not tell you a maximum dose, you do not need to know it. Does everybody understand that? Seeing no hands, I will go on. Your next typical antipsychotic is Prolixin. Both Haldol and Prolixin come in injectable form, and it's a very thick, oily-like substance, and it hurts when you inject this, okay? So that's why we only use IMs in emergency situations, or if they're getting what we call an LAI, a long-acting injectable, okay? So far you've learned two typical antipsychotics. You've learned your Haldol and Prolixin. The only other one that you're responsible for, after examples, it says Thorazine, okay? You do not need to know Narvane or any of the other ones. So your typical antipsychotics that you're responsible for are your Haldol, Prolixin, and Thorazine. These are typical antipsychotics used to treat positive symptoms of schizophrenia or psychosis. Does everybody understand that? Okay. Your next classification are atypical antipsychotics. These treat both positive symptoms and negative symptoms. So think in your mind, from the previous slide, what are the positive symptoms? Okay. Now the negative symptoms are things that we have that are taken away, okay? So we all have the ability to speak. Some people with schizophrenia cannot speak, and that's called alogia, okay? Or anhedonia is we all have the ability to feel pleasure. Some patients with schizophrenia or other psychotic disorders, they cannot feel pleasure. Do not start learning the negative symptoms at this time. When we have our whole lecture on schizophrenia, we'll go more into that. But just look at all the alogia, affective blunting, anhedonia, evolution, apathy. All these start with A. So what you might want to do is, on a flashcard, because I'm really big into flashcards, is put it on one side when we go into this lecture on schizophrenia, put negative symptoms of schizophrenia and then list them all on the back. So your first medication of atypical antipsychotics are aripiprazole. Abilify is a trade name. Maximum dose is 30 milligrams. Next one is Clozaril, and I have a whole slide on this. Clozaril is the mother of all mothers of atypical antipsychotics. Very expensive choice, and there's a lot more testing that goes in there. Latuda treats more bipolar depression. One thing with Latuda is when you take this medication, you normally take it in the afternoon, you have to take it with some food, okay? At least 300 calories. Zyprexa, you'll see all kinds of this. Zyprexa. I'm not going to give you a maximum dose on Zyprexa because it depends on what you treat. But Zyprexa we use a lot. I like it because it brings, if somebody's extremely manic or somebody's extremely psychotic and hasn't been sleeping, it can be sedating, so it brings them down pretty fast. Next one is Invega. Invega comes in oral form and IM as well as a long-acting injectable. Next one is Seroquel, and you'll see a lot of Seroquel as well. A lot of people think Seroquel is a sleeping pill. Well, Seroquel is an atypical antipsychotic. Maximum dose is 800 milligrams in a 24-hour period. The problem with Seroquel is that And with all atypical antipsychotics, there's a tendency for a lot of weight gain. So we really have to monitor that, because patients say when they take these medications, they want to eat things that are sweeter. Okay. Next one is Risperdal. Maximum dose of Risperdal is 16 milligrams in a 24-hour period. Two major adverse effects that you don't want to see with Risperdal. In males, it can cause gynecomastia, which is like male breast. And in females, it can cause amenorrhea, absence of them having their period each month. Next medication is Geodon. And with Geodon, you want to make sure that an EKG is done before a patient gets Geodon. It's not your responsibility to order the EKG, but it's your responsibility to make sure it is there. Okay. If it's not there, you call the provider and get that ordered. And the one thing that I like about Geodon, there's less affinity to weight gain. So we talked about Clozaril, and what's the classification of Clozaril, everyone? It's an atypical antipsychotic. Okay. It's the last treatment option for psychosis. So normally you don't put somebody on Clozaril until they've been on everything else. So if you see a patient that comes into you and on Clozaril, you know they've been in the system for a while. It's very expensive. They have to go for weekly blood draws, because the main side effect of Clozaril is it can lower your white blood cell count. And that's why before we start somebody on Clozaril, we do a WBC with a CBC, and we're looking at their WBC and their ANC, which is their absolute neutrophil count. Okay. So let's say we get that lab back, it's normal, the provider orders a Clozaril. Every week for the first 4 to 6 weeks, they're given the blood test to see if their WBC and their ANC is going down or depleting. And once they're stable, we do it monthly as we see them. A lot of pharmacies will not dispense Clozaril unless there's a WBC. Okay. So one question you're going to ask your patient, number one, is how are you feeling? Have you had any recent infections? Because if they've had recent infections, that means that they might be having some kind of infection. Does everybody understand that? Any questions? Seeing that there are no questions, we will go to the next slide. So EPS is extrapyramidal symptoms. These are adverse effects from antipsychotic medications, both typical and atypical. But basically speaking, typical have more EPS, okay? And what's EPS caused from? It's caused by a blockade of dopamine receptors, okay? And what is dopamine? Anybody? It's a neurotransmitter, okay? And there's 3 medications that we use to treat EPS. And remember these A, B, and C: Artane, Benadryl, and Cogentin. And I'm sure everybody in this class has probably taken Benadryl sometime in their life. It can make you sleepy. Artane and Cogentin, not so much, but all these medications are drying. So we got to be very careful when we give these medications to what population. That would be older males with prostate problems, BPH, because if a male already has problems urinating, then drying them up will cause more problems. Okay. Females do not have prostates. Okay. So side effects from these ABC medications, these anticholinergics, are dry mouth, nasal congestion, urinary hesitation, urinary retention. Okay. So just be very careful. Okay. And again, we normally give lower doses to the elderly. Benadryl over the counter is 25 milligrams. Benadryl prescription is 50 milligrams. And you'll see a lot of medications like that. If your doctor ever gives you a prescription and you know they sell it over the counter, instead of paying money for the prescription, you just might want to get the store and just double up on it. Okay. Some other side effects can be orthosthetic hypertension, some sedation, decreased sweating. That's why if you have a patient or yourself that's on any of these medications, you want to watch out for strenuous exercise. And we're halfway through this lecture. Okay, aren't you excited? Okay. Some other extrapyramidal side effects, acute dystonic reaction. We'll talk more about dystonia when we're talking about schizophrenia. Some really tight muscles, okay, akathisia, internal restlessness. And one of your goals this semester will be to do an AIMS exam, and we'll talk about that. And as one of your tickets to class, you'll actually be doing an AIMS video along with a mental status exam. Oh, how fun. TD is tardive dyskinesia, and this is non-reversible. So you'll see a lot of homeless patients that suffer from psychiatric illness with TD because they're not monitored and they're on these antipsychotic medications. And where it says after long-term use, I've seen this pretty in short periods of time. And you'll see these patients with their tongue sticking out, their neck contorted. It's very scary looking, okay? Unfortunately, patients that have psychiatric disorders that are in nursing homes, they're not really monitored. Law requires that a psychiatrist or a psychiatric NP go out once a month to see them. A lot of times the staff is not really up to par as far as being educated on TD. So as soon as the first symptom is seen, the provider needs to be monitored, or needs to be notified, excuse me. So NMS, take this slide to bed with you as well. It's neuroleptic malignant syndrome. It's rare. I've seen it once in my career. I've seen this on ATI in the boards though. It can be potentially fatal. And the cardinal signs of NMS are hyperthermia and altered level of consciousness. And hyperthermia is an elevated temperature. Let's say in the morning, the patient's temperature is 98.6. You take it again, it's 104, it shoots up. This is a medical emergency. So for example, if you're in an acute care hospital, a code's called on this. If you're in the PUF, like a freestanding facility, we call 911, okay? You need to get the patient off the unit, okay? And treatment is a medication washout. We stop all medications, okay? And you have to monitor these patients. And the bad thing about this, number one, the fact that they could die. Number two, if they've been unstable on their antipsychotic for a period of time and you do a washout, you stop all these medications, is that a lot of their psychiatric symptoms can come back. And normally what happens is a week to two after they have the washout, that's when we start introducing the medications again. And probably a different class or a different medication within the class. Does everybody understand that? Take a deep breath, stand up, get some water, go and pee, hurry back. Well, you don't have to hurry back because this is recorded. Next is your mood disorders. And under mood disorders, think about two big classifications. This would be your major depression and your bipolar disorder. Major depression and bipolar disorder, okay? And antidepressants are used as well as mood stabilizers. So your first classification of antidepressants are your SSRIs, your selective serotonin reuptake inhibitors, and these are your first line agents. And when we talk about first line, does anybody know what that means? That means that these are the first classification of medications that we go to. Typically because they're more effective and there's less side effects. And the examples of SSRIs are your Prozac, maximum dose is 30 milligrams in a 24-hour period, Luvox, Paxil, Zoloft, and Celexa. Those are the main ones. Those are the main ones, okay? SSRIs, they take a period of time to take effect. They can take, 4, 6, 8 weeks, and your patients need to know that, because unfortunately in our society, we want everything fixed really fast. Okay. And so you need to let your patients know that, because what I don't like is, let's say I prescribe this, I'd see the patient in a month. I said, how are you feeling on your medications? Well, I stopped taking after 3 days because it wasn't working. Okay. So now they're back at square one. Okay. So you need to let your patients know you need to give the medication some time. Okay. Your next one are your TCAs, and it's your second line agents to treat depression. And the only medication that you're responsible for is Elavil. And normally we prescribe Elavil a lot of times off-label. Does anybody know what off-label means? That means we're prescribing it for other than a reason it's for. So Elavil, it's for depression, but a lot of times we'll give it for sleep. Well, before I move on, with the SSRIs, when we see these are the first line agents, we have novel antidepressants that are first line agents as well, but that's on another slide. I've already talked about Elavil. TCA, you can die from taking a TCA overdose. So I really don't teach a lot about TCAs because you don't see those medications a lot. One great thing about having me as your professor, besides the fact that I know what I'm doing, we all know what we're doing, and I'm funny and not funny looking, is the fact that I'm in the practice and I'm up to date on my medications. So I'm only gonna educate you on current medications that you'll actually see in your practice. So TCA overdose, remember ABCs, okay? So any overdose, you look at their ABCs, make sure blood pressure, heart, make sure they have oxygen, and go from there. And with a TCA overdose or any kind of overdose, you would not have, you'd get them the care they need on your unit, but you'd call 911 or you'd call a code. Third line agents, again, these are your MAOIs. And the only thing with MAOIs is, and you might see this on ATI or your boards, is people that are on MAOIs, they cannot have tyramine, and tyramine is an amino acid. So they can't have, red wine, beer, alcohol, caffeine, chocolate. And you need to educate your patients when they're taking OTC, over-the-counter medications, to look at what the ingredients in the OTC and these medications are. Because a lot of them have alcohol, okay? And the problem when you mix an MOI with any of these ingredients or things listed, it can cause a hypertensive crisis. And what a hypertensive crisis is your blood pressure is 120, let's say 120 over 80. It can shoot up to 240 over 160, okay? So you really need to monitor this. And another thing you want to talk to your patients about when they're on any medications, and the voices are telling me to tell you this, is that you want to make sure that they're not on natural supplements too, because our society is really big on natural supplements, okay? So again, teaching about MOIs, they can take 2 to 4 weeks, so you need to have your patients be patient. They can cause sedation, so make sure they avoid driving. Check your OTC medications, okay? Stay away from the foods that have that amino acid tyramine in it, okay? And if they have a hypertensive crisis, they're getting a headache, chest pain, contact their provider, okay? And stop the medication. So your your first line along with your SSRIs, and what does SSRI stand for? Selective serotonin reuptake inhibitor, are your novel antidepressants. These, along with your SSRIs, are used to treat depression. Some providers combine the type. I normally, will start a patient on a medication. If they fail that medication, I'll start another medication in the same class. If they fail that medication, I'll switch to a different class. Okay. Your first medication is Wellbutrin. Maximum dose is 450 milligrams in a 24-hour period. Okay. It's also manufactured under Zyban, and Zyban is the exact same thing as Wellbutrin, but Zyban is for people that smoke. It helps with them to quit smoking. Next medication is Remeron. Maximum dose is 45 milligrams in a 24-hour period. Good thing about Remeron, it helps for sleep as well, and it helps for to increase appetite. So when patients were back in the day when HIV was prominent, we'd give a lot of patients Remeron as well because it would stimulate their appetite. Because what happens with patients that have AIDS is they would not want to eat. They would not want to eat. Okay. You don't need to know Seroquel. You need to know Deseril, which is Trazodone, and Effexor. Trazodone is used off-label. And what is off-label? Off-label means that we're prescribing it for some other reason than what it is intended for. So we use a lot of Trazodone for sleep. Okay. Effexor is a good medication, and we can use that for both depression as well as anxiety. And let's take a 5-minute break a 5-second break when I just respond to this text. Get up, take a stretch, take a sip of water, move around, say something positive about yourself, because that works as well. And now we are back. So with suicidal potential, some patients will get really anxious when they read the side effects. It says this medication can cause people to think about suicide. And I'll talk about this more in class. When you're extremely depressed and you're not getting out of bed, you don't have the energy to act upon that. Really, you need to look at the patient, 3, 4, 5, 6 weeks in and monitor them. And each time I meet with a patient, even if they don't have a history of feeling suicidal, I will ask them if they're having any thoughts. Okay. Any thoughts. And remember, with the MAOIs, it's more of a chance of harming yourself than an SSRI or a novel antidepressant, which are what? The first line treatments. Serotonin syndrome is a drug-to-drug interaction when you're taking an SSRI with these other medications, and signs and symptoms of SS, serotonin syndrome. And what is serotonin? A neurotransmitter. You'll see some mental status changes, restlessness, agitation, and you're probably in your life not going to see serotonin syndrome, okay? But I have seen this on ATI and the boards, okay? Your next classification are your mood stabilizers. And when you're thinking about mood stabilizers, think of bipolar disorder and major depressive disorder. And mood stabilizers, you'll see these classified as antiemetics as well. So your 3 agents are your lithium, Tegretol, and Depakote. There's more, but these are the medications that on your puff worksheet where it says therapeutic range. If you have a patient on one of these 3 medications, these are the therapeutic range. So your first one is lithium carbonate, and the therapeutic range is 0.6 to 1.2. And the way I remember these is that 1.2 is twice 0.6. And then you look at Depakote where it's 50 to 100. 100 is twice 50. Okay. Does everybody understand that? So lithium carbonate therapeutic range is 0.6 to 1.2. Valproic acid, also known as Depakote, is 50 to 100. Tegretol is 8 to 12. And how I remember that is we eat breakfast at 8, lunch at 12. So when you're trying to remember these medications or these ranges or these maximum dose, do whatever works for you. But the biggest thing is you need to study these all along. Do not wait to the last minute. Okay. So some, did I skip a slide? So some other antiemetic agents that we use on Zyprexa and Abilify. Remember, both Zyprexa and Abilify are atypical antipsychotics. If I ever ask you the classification of Zyprexa or Abilify, it's an atypical antipsychotic, not an antiemetic agent. But like I said, I like Zyprexa because it will bring somebody down really fast as well. And Abilify, a lot of times we use this as adjunct therapy. Does anybody know what adjunct therapy is? That is when we take one medication and add it to another. When I'm treating, or when we're treating somebody with depression and we put them on Zoloft, and Zoloft is what? An SSRI. An SSRI, selective serotonin reuptake inhibitor. And if, let's say we get to the maximum dose of Zoloft, which is 200, and they're not responding really well, we'll add Abilify, and it's sort of like gives them a jump start. Okay. So lithium therapeutic range is 0.6 to 1.2. Okay. Lithium is metabolized through the kidneys. This medication is a natural salt. It can cause fatigue, headaches, impaired memory. So when somebody's starting lithium, you need to go through these and let them know if they experience any of these. Okay. They need to drink a lot of water. It is a natural salt. And we have to monitor their thyroid function and lithium level. And since this is a natural salt, this is metabolized through their body really fast, okay? And biggest thing with lithium, it's contraindicated in cardiac patients, renal patients, because it's metabolized through the kidneys, and pregnant patients. It will cause fetal demise. Anybody know what fetal demise is? It's death of the fetus. So when I'm educating my patients on this medication and they're sexually active, I always tell the couples to use 2 forms of birth control, a condom and the pill, or any other birth control, but it should be 2 forms. So you always want to teach your patient about side effects with any medication, because if you don't and they have a side effect, they might stop the medication. Okay. And the higher the level of lithium in your system, the more severe the side effects. Okay. They should take lithium with food. If they have swelling, elevate the part of their body that's is swollen. Avoid driving because it can cause some fatigue until they're stable on it. Okay. And lithium toxicity, this is what you expect. So normal lithium level is 0.6 to 1.2. So when you get to the areas of 1.5, that's when you might have some diarrhea, some vomiting. And whenever you have diarrhea or vomiting, okay, that's your body's way of saying it's trying to get this out of this system. Okay. So I have friends call me all the time, hey, I'm having some vomiting, diarrhea. Can you give me a pill to stop this? I'm like, no. Okay. Whatever is in your system, your body's trying to get rid of it. You want to make sure your patients or yourself, you stay hydrated, but get that foreign thing out of your system. Lithium levels at 2 to 3. This is when you have tachnia and giddiness. You have some ringing in the ears, blurred visions, and large outputs of urine. And that's because your body's trying to get rid of it. Just like when people are diabetic, they'll release a lot of urine because it's their body's way of trying to get whatever substance in out. Okay. You go up to 3, you're going to have some organ failure, some systems failing. Okay. And this can lead to coma and death. And lithium level of 4, where it says poor outcome, that is you are dead. That is you are dead. So this needs to be monitored. Very, very, very important. Okay. So there's no antidote. Normally we just stop the lithium. Okay. So before you give lithium, what are you checking for in the chart? A lithium level, correct. Okay. So normally if somebody's lithium is on the elevated side, we'll hold it for a day or 2, then restart the lithium. Okay. If they overdose, we'll definitely give an EKG. We'll give some charcoal. We'll do a lavage. I've had 2 patients in my career, we've had to put them on dialysis for a period of time because their lithium level was so high, okay? So what is the therapeutic range for lithium? What is the therapeutic range for Depakote? What is the therapeutic range for Tegretol? So lithium is 0.6 to 1.2, Depakote is 50 to 100, and Tegretol is breakfast lunch is 8 to 12. Okay. So Depakote, this works on the GABA, and what is GABA? A neurotransmitter. Okay. Therapeutic range, serum value is 50 to 100. And when we ever talk about serum, that means we can take a blood draw. And this treats rapid cycling, okay, of bipolar. Okay. So when you think about rapid cycling, think about being on a bike pedaling, depressed, manic, depressed, manic, depressed, manic. This stables the patient out. So some side effects can be hair loss. No, I'm not on Depakote. Some weight gain, tremors, GI upset, thrombocytopenia. And you want to look at their LFTs, their liver function test, because this is metabolized through the liver, okay? So does anybody know what a BMP is? Does anybody know what a CMP is? A BMP is your basic metabolic panel. Your CMP is your complete metabolic panel, okay? So your BMP has all your electrolytes. The difference between a BMP and CMP is the CMP has your AST and ALT, which are your liver enzymes, okay? So make sure you know that. Your third mood stabilizer is your Tegretol, and this is good for people that don't respond, patients that don't respond to your lithium and your Depakote, okay? This inhibits kindling, and think of kindling as little sparks that come out of fire, okay? And this normalizes the sodium channel activity, so the salt, okay? And again, the level is 8 to 12. And side effects can be, you know, anorexia, sedation, nausea, drowsiness, agranulocytosis, okay? And you need to monitor for SJS, and SJS is Stevens-Johnson syndrome. So in your spare time, go on YouTube and look up Stevens-Johnson syndrome. You'll see some really nice pictures. Other drugs used to treat bipolar disorder are your Klonopin, your Ativan, which are benzos, your Clozaril, which is what? Atypical antipsychotic. What labs you have to monitor in Clozaril? It's your WBC, looking at their ANC. Risperdal, maximum dose is what? 16. The 2 adverse effects are gynecomastia and amenorrhea. What are gynecomastia and amenorrhea? Seroquel maximum dose is 800 milligrams. Neurontin is another new medication. Neurontin, you'll see a lot of this with people that have neuropathy. It's used to treat anxiety as well. Lamictal, and again, with Lamictal, you have to monitor for SJS, Stevens-Johnson syndrome, and Topamax, okay? And we give a lot of Topamax when patients are on atypical antipsychotics, because what's one of the major effects of atypical antipsychotics is weight gain. So Topamax can be given to help them eat less. Take a breath, it's almost over. Well, not the semester, just this class. So anxiety disorders, we use analytics used to treatment of GAD, OCD, panic disorders, PTSD, phobic disorders, and insomnia, okay? And you have a lot of people that like this classification of medication, benzos, but benzos can be very addicting. So I normally only give them for a short period of time. And benzos work on your GABA, which is what? A neurotransmitter, okay? And it brings people down. The problem with benzos, this can be physically and psychologically addicting, okay? And with physical addiction, if you stop these abruptly, what can happen? A seizure, okay? And I'm sure you've read in the paper, like the Hollywood type, they'll die because they'll be drinking alcohol and taking benzos. And these make your CNS go to sleep, and you can die. You can forget to breathe. So it's very, very, very important that these things are monitored. So they're used as analytics, hypnotics, muscle relaxants, anticonvulsants, and amnestics. And if any of you guys decide to work in the emergency department, you'll see these come in suppositories. And like if a child comes in with an elevated fever that's having a seizure, a lot of times these come in rectal form as well. One medication I really like is Boost Bar, and Boost Bar treats anxiety, but it can take anywhere from 1 to 6 weeks to take fully effective. Okay, so what I do is I'll normally pair up a benzo, low dose Ativan along with the Boost Bar. And as I titrate up on the Boost Bar, I titrate down on the Ativan. That's beyond your scope. But dealing with somebody that has dual diagnosis, and that's a person that has a mental disorder along with a addiction disorder, is I like Boost Bar because it will help both. Okay. And it's a pretty benign drug. It doesn't interact with anything else. But again, some patients don't like it because they want that instant relief, and Boost Bar does not have that. Okay. So some specific benzos that you need to know are your Xanax, Librium, Clonopine. You do not know to use Trexine, Valium, Ativan, and you don't need to know Serac. So again, you're responsible for Xanax, Librium, Clonopin, Valium, and Ativan. And you'll see a lot of Ativan on the unit. We use a lot of Librium as well for people that are coming off of alcohol, because Librium has the longest half-life. Some other medications that we use for anxiety are Inderal, Prozac, or any of the other SSRIs, your Effexor. Rofinol is a date rape drug. You don't need to know that. We don't really prescribe that. Okay. And overdose of any of the benzos, somnolence, confusion, coma, diminished reflexes, and hypertension. If somebody has an intentional overdose or unintentional, we'll lavage them out. We'll stick an NG tube down and lavage them. Charcoal them as well to get the drug out of their system. So I already touched on this. Normally, not normally, but some in the elderly, we use a small amount of the medication. Ativan is my go-to. Restorol we use for sleep. But again, if somebody comes in and complains of sleep, I talk about sleep hygiene. And what sleep hygiene is, you won't be tested on this, is, no sugar or caffeine after 2 p.m. Make sure that maybe eat a little protein before you go to bed. But again, if you're not doing anything all day and you're not getting burning some calories or getting some exercise, you're probably not going to sleep at night. And with your patients that do complain that they're not sleeping at night, ask them if they're sleeping during the day. Okay. Valium and Librium are contraindicated for the elderly because their half-lives are extremely long. Okay. So when you're teaching your patient about benzos, benzos are not intended for minor stressors. So ask the patient, how do they maintain their stress? Again, each of you, if you guys get up each morning, take a good brisk 15 or 20-minute walk, that's going to release serotonin from your gut. It's going to bring your mood up and your anxiety down. Try it. Okay. Over-the-counter drugs may enhance benzos. Why? Some have alcohol and other ingredients in them. Okay. Talk to your patients about herbals, and if they're taking any other herbals, don't drive, because you guys, that even if you have a prescription for Ativan or any other benzo and you're caught driving and they do a blood test on you and you come back with these and you're under the influence, do not exceed the prescription antidepressants because you can die. And remember, don't stop the benzos abruptly. They need to be titrated down because you will have a seizure. We're going to talk more about dementia. One of the groups is going to be giving a presentation on dementia. So we'll go into this classification when we talk about that. Wow. So these are your medications. You will have a learning experience when I see you on Wednesday. Okay. And we will talk about this more. There will be 4 questions on medications or mood disorders or schizophrenia specific to medications. Okay. Actually, there might be 3 or 4 or 1 or 2 on legalities. I've already posted the legalities one, both the PowerPoint, okay? And again, this is a class that you cannot wait to the last minute to study because we have a lot of information, okay? And please, 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 please practice self-care, okay? You need to get good sleep, good diet, exercise, socialization, get up and move and walk. I will be posting the ticket to class by 5 p.m. on Tuesday. Okay, you take care and you have a great day. I appreciate you all, and I cannot wait to see you progress through this semester.